You're listening to Medscape's In Discussion series on type 2 diabetes, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Carol Wysham. Dr. Wysham is an endocrinologist at Rockwood Multicare Health Systems in Spokane, Washington, and a clinical professor of medicine at the University of Washington. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Welcome to Season 3 of the Medscape Type 2 Diabetes podcast series. Today, we'll be discussing continuous glucose monitoring in practice. First, let me introduce my guest, my dear friend, Dr. Grazia Aleppo. Dr. Aleppo is a professor of medicine in the Division of Endocrinology, Metabolism, and Molecular Medicine at the Feinberg School of Medicine at Northwestern University in Chicago, Illinois. She is also the medical director of the Northwestern Medicine Diabetes Training and Education podcast. Dr. Aleppo, welcome to the Medscape In Discussion Type 2 Diabetes podcast.
Thank you, Dr. Wysham, for having me here today. It's a pleasure to be here with you.
So, Grazia, you have been on the forefront of the use of continuous glucose monitoring in patients with diabetes. In the early days, could you even imagine the impact that CGM has made in the care of our patients with diabetes?
This might sound so strange to you, but I was a fellow when the first CGM with the cable was introduced to the market. And I had the Cupid arrow strike my heart. And I'm thinking, this is it. This is going to make a humongous difference in people's lives. I had no idea that they were becoming so very useful and user-friendly and ready to be used without cables. And the fact that we could see numbers and see trends and make the invisible visible, it was amazing. Now, I was hoping it would become better and better, but this really exceeded my expectation. I'm so happy the CGM is going so far in medical care.
We want to thank you for all the research that you've done to support the use of CGM in our practice. Thank you. So let's start with the newest recommendations that were outlined in the 2025 ADA Standards of Care for Patients with Diabetes. Will you review the latest recommendations? Let's first start with focusing on the language about patients on insulin.
I had the opportunity and the privilege to work in the professional practice committee for the past 3 years. And so I've seen the development and the changes in the guidelines in the technology section. And so this last year, we decided that it was time to put together all the insulin users without specifying the type of diabetes, youth or adults. And so the 7.15 recommendation states that people with diabetes on any type of insulin should use CGM. And that is very important because we need to start understanding that CGM is going nowhere but staying here. Not only that, it's actually expanding. And so the point is everybody that uses insulin, any type of insulin, it doesn't have to be multiple daily injection, can be basal, it can be correction only, can use, it should use a CGM.
I think your last point is really important. Correction-only insulin is actually common as we pull people off MDI and just, maybe they're on basal plus a GLP-1 or maybe just a GLP-1 alone, but still having the insulin for correction. I think many people don't think of that population as being appropriate for CGM, and I agree with you. So how about changing to what I think is really a monumental change in the language about using CGM in patients with type 2 diabetes who are not on insulin? Would you review those recommendations?
Indeed, I'm very proud of it. 7.16. I even know the number. They took a while to put that separate. And I had to go and really dig into the literature to make my case and say there are enough data today to state that CGM is an option. Right now, as you remember, the recommendation states consider using CGM, and the recommendation is level B, which is pretty high, knowing that level A grade will be a gold standard of randomized controlled trial. B is just below it. And the reason why we wanted to put the recommendation was that the data are there. We need to be aware that CGM in people without using any insulin is paramount. It's so important. Because to this patient to whom we're given a glucose meter, they never used it. They have no idea where the glucose levels are. And here come the CGM and they say, oh my gosh, I never thought that this or that could happen to be a response to a meal, stress, sickness, exercise activity. And so that for me was a hugely important thing. And now we're hoping, of course, that we could have a recommendation A. But I also want to mention that these clinical trials better be done soon because very soon it won't be fair to do a clinical trial and taking people off of CGM. Well, what would want to do that?
In my clinical practice, I have a lot of patients who are not on insulin on CGM, and they cannot imagine not having it. They are so in tune to what affects their glucose levels. And as you know, and you participate in the research, patients on type 2 diabetes not on insulin with no instructions can improve their glucose control just by what they see on the CGM.
More than that, patients in my clinical practice who were able to come off of insulin, stay on GLP, and maintain a very high time in range. And so I asked them, I said to this patient, why do you want to stay on CGM? I mean, no longer take insulin. She said, oh, I'm not going to give it away ever. It really changed my life. And I believe her. And this is more than one person because they really have been able to own their diabetes. It's no longer the doctor or the provider, the clinical practitioner say, do this or that. They say it to themselves every day. We see patients twice a year, 3 times a year. It's not possible to make changes in their motivation with just one meeting. But when they see the immediate feedback in the moment, they can say, okay, I can do this to change and make a better choice for myself. That is huge.
Yeah, I agree. So I know that this isn't in the standards of care, but in your opinion, do you think all patients with gestational diabetes should be on CGM?
I think so. I have a strong belief that these patients who are at very high risk for everything, macrosomia, all the risk of, perilabor, but also when they have delivered, they have a risk for diabetes. Why do we wait for week 28 and we give these people this huge amount of sugar? We give them a stress test to the really stress test beta cells, and then we want them to eat nothing without any feedback. It's not possible. And we should really try to accomplish what the HAPO study showed us. It was, the glucose should be really lower. We can't think about these falsely sort of arbitrary numbers in the OGTT. So I'm thinking about the woman with gestational diabetes. I'm thinking that this person has so many stressors. And then they are supposed to have this very strict meal plan without any feedback. And that becomes very difficult for them to do, or let alone go on insulin. So I feel that we should really consider placing gestational diabetes patients on CGM as soon as we can. We'll have better results, better outcomes for the mother, for the baby, less macrosomia, less complication during the labor and delivery, and also knowledge of the person who has the CGM to understand how to manage these very tight glucose levels. It's very hard to achieve.
I find that helping patients with CGM understand when it's time to start insulin, as well as knowing when it's time to start insulin, CGM really does help that process, and people accept it greater when they actually see it with their own eyes. So I know you are in a university type setting, but can you describe the patients you see in clinic who have diabetes and which patients for whom you will prescribe a CGM or suggest it for your patients?
So we have, a tertiary center, referral center, but we also see a lot of urban patients because some hospital is close in Chicago. So we have a lot of patients on Medicaid, on Medicare, and of course, commercial insurance. So we have a very diverse population, people who don't even speak English. And I tell you something, we have about 99% of patients with type 1 on CGM. That's for us a given. I don't remember seeing a glucose meter in type 1. For type 2, we've been very engaged in trying to put a patient on CGM, mainly because in Illinois, Medicaid covers CGM for people on insulin. And so we try to really maximize on the fact that there is coverage. And I tell you, some patients of mine, even those who don't speak English, when they are placed on a CGM, they have made such dramatic changes. And I have a specific patient that I'm thinking right now who told me, my family is better. My glucose are fine now. I've changed my meal planning. My wife and I go for walks. And without this tool, I was convinced I couldn't eat any different because of my cultural choices, whatever. So that's one type. And then I have the patients in whom they start with us with very high A1C. They're going to be placed on CGM because I'm using insulin. They have never seen the glucose because we have something called the tune-up pathway where we have patients who are with high A1C from primary care coming to us into education, then endocrinology, and they've never seen their glucose before. They don't understand why they want to see that. And then these patients very often come off of insulin. They go to a GLP, maybe a SGLT2. By the time they see us in the following 6 months, they are not taking any insulin. And so it becomes a challenge for payers, but we see that they might need PRN, and that's the correction. There's still, quote unquote, insulin, but every day is not a necessity. And they truly do very well. I have some barriers, and those, of course, are for patients where there is a specific policy in their insurance coverage where they have to be on some insulin. I don't get much resistance from patients, except for those who feel that it's not going to be better for them. And I think is if they just allow me to do a professional CGM, I can prove to them that it's not the case. But I need to work with the patient. And very often, I work with patients over time. And just recently, I have a gentleman who's been using insulin and a GLP and an SGLT2, whose A1C is going up. And I said, you need to go on CGM. And I've been saying this many times. Maybe a month ago, he said, I need to be on CGM. Can you please write this script? This guy finally understands that he has no clue why his glucose are fluctuating. He doesn't understand why one day wakes up at 220, one is 140. And so now it's going to be so much easier for him to be on CGM. And he actually asked. So you need to work with the patient, be yourself patient with your patients, because you need to guide them. They might not know what this is. Sometimes they come to you and say, I want the thing on my arm. And they come to you with this statement and say, sure, no problem. And so you work with every individual where they're at.
I have to say that there are many patients in my practice in whom it took 2 or 3 years before they would actually agree to go on CGM. And one of them came and said, this is so helpful. I can't believe I didn't do this sooner. So I agree. You do have to present the data, the benefits. The professional CGM, which I'd like to get to in a minute, is sometimes really helpful, as you pointed out. So can you explain how and when you use professional CGM in your practice?
So right now, because we have so many patients on personal CGM, we use professional when the patient go for diabetes education. It's a great opportunity. They come to us with no glucose levels. We have no idea where the glucose levels are, and there is an expectation to fix them. What am I going to do? I don't have any data. So our educators put the patients on professional themselves. They interpret. I look at them come up with a plan, but we have a place to start. Otherwise, we wouldn't know what to do with them. I try to do them unblinded as much as I can, with the caveat that sometimes some people shouldn't see their glucose because they're going to go so upset and they're going to feel bad about themselves. And so in those situations, when I know the patient is going to be really upset, they feel sort of guilty about the diabetes and so many things like that. In that case, I will use it blinded, but it's the minority. And then the instructions are, don't freak out. Don't be worried. Just look at the numbers for the first few days and they change a few things. Take notes. When you come back in 10 days, we discuss what you've changed and we can see on the screen the results of your choices. And so that's how I use, but I use it less than before because of our desire to expand CGM to as many people as possible.
Yeah, I think that's appropriate. I have a patient at professional CGM, and I tried to convince him, like you said, just do your normal thing for a few days. He did it for one day. He changed everything in his diet, and his A1C went from 9% to the estimated A1C on the CGM of 6.9%. It was in 2 weeks. I mean, obviously we can't see the A1C change in that time, but it was really dramatic. So practical tips for using professional CGM in practices, because it is something that I think is helpful. It's well reimbursed by almost everyone. Is there a specific brand of CGM you use? Do you know how the whole ordering process happens? And you say how it works with the educators put it on, but MAs can put it on in the office. You don't need to be an educator to actually start the process.
That's right. So we talk about this also with our colleagues in primary care. And we say you need to have a champion in your practice. Anybody can place a CGM. Now, because of the choices of having the ability to do blinded and unblinded that have been using the G6 Pro, because of that opportunity, we order them in a clinic. We have them always on hand. We order a bunch at a time, and then we make sure we use them all up before they expire, of course. But that's what we've chosen to do for the ability to do both blinded and unblinded, because sometimes you want to have the patient see the numbers so they can get the knowledge and say, okay, it's what was missing before, to sort of overcome the resistance of, say, I don't need education, I don't need this, I know better, when they, in fact, they actually realize they need a lot of help. So I would suggest from primary care or any other practice that doesn't have an educator because they're not so easy to come around, I would say have an MA, understand how to put it on, help the patient to put the app on, and it will be so simple. And the patient comes back and you can bill for that. It's all a billable service and you get so much more information from your patient. I would say you don't waste 3-6 months by just wondering. You know what's going on and you can get implemented a plan. And I always feel with patients with diabetes, I'm always behind because they come to us already with high A1C, high glucose for a while. So already thinking them at risk. So I'm always in a hurry to help them out because I want to try to stop the continuation of the glucotoxicity and the insult to the body that can cause complication later on. So to me, it's like the sooner we get there, the better. And therefore, somebody comes to you with a high number, high A1C, you need to know what to do. It might be postprandial hyperglycemia, it might be fasting, it might be both. Without the knowledge, you can put a patient on a very high dose of long-acting and get nowhere because their meal time is not covered. So that's where it helps the provider in any setting, any location, whether private, public, primary care, endo, to get a plan for the patient fast.
I just want to get back to something that you referred to earlier, and that is the state coverage that you have for CGM or patients on insulin. That is a state-by-state regulation, and it behooves all of us to address the people making the decisions on our state Medicaid plans for covering. And people want to hear our voices, and we need to speak for our patients to make sure we can get those.
It was a long process, but it was worth it. We really were so dedicated and motivated. We spent a lot of time of our own free time, but we felt that now they can get CGM in primary care, any insulin. And so that is a huge advantage. I feel that our state has been very good into understanding CGM.
You're very lucky. Now I want to get to a controversial topic. Do you think CGM could replace traditional testing for diagnosis of prediabetes or diabetes?
Oh boy, that is such a hot topic. So I feel that, in fact, you can have somebody with prediabetes see their progress to diabetes. Now, I do know that you need to get a plasma glucose because sometimes CGM might overread, underread. I understand that. But I also feel that people with prediabetes are so lost. They have nothing, only about metformin and lifestyle, and nowhere to say, my goodness, my glucose is going so high after eat a meal. So I think that should be considered. And if I may say, the over-the-counter biosensors are very helpful for that. They really show you those fluctuations that people without diabetes or pre-diabetes do not know they have. And so is it time to substitute? I would try to remove the A1C if I could for management because it's not helpful. For diagnosis right now, I think the 6.5% is even too high. We need to do this earlier because a 6.5% can have also glucose in the 200. 230. And so it depends. It's not just a number. It's the progression of the day, the time they spend between 70 to 140 rather than 70 to 180. And so there are data that show a very good paper from Nicole Spartano that was just published recently. It was like a normative for how much time do people spend in glucose level. And people without diabetes spend about 3 hours a day over 140. The pre-diabetes spend 5 hours a day over 140. That's almost double. And then with diabetes, go to 13 hours. So between 5 and 13, there are a lot of hours you spend above target. So why not try to do this earlier and keep people healthier sooner?
I think that's really important. The information that a person with prediabetes can get, even if they wear the unblinded professional for 2 weeks and just start looking at the different aspects of their diet. And you can do that periodically throughout the time. So I personally think that sensors are really helpful for diabetes. But again, getting payment is one thing. And I would really like you to consider what we've talked about. Are there any other points that you think are important for our audience to hear about your use of CGM or your views of CGM in practice?
I would like to say that we need to stop comparing CGM to BGM. They have nothing to do with each other. And we should forget that in people with type 2 diabetes not on insulin, BGM didn't work. Of course it didn't work. It didn't tell anything to the patient or to us. CGM is a new frontier. Well, not so new, it's 25 years old. So we need to accept that really the best way to address glucose management to a patient with type 2 diabetes, especially when they're early in the disease. They can actually go and maybe go into remission. Why do we have to wait until they need insulin? Why are we wasting 5 years of their lives, making them a risk for complications sooner than just say, get this done now. We would never think this way about cancer. We need to understand that it's a serious disease. The sooner we make our patients healthy, the better their life will be.
I think that is a really important concept. And I like to add to that. You talked about comparing BGM to CGM. And I always tell patients, the accuracy of blood glucose monitoring is very close to that of CGM. There are some specifics where it's maybe a little bit more accurate. However, when people do it in real practice, they have more chance to screw up the results on a BGM by not having the appropriate preparation of their fingers than the CGM. And so I do the same thing. I say, just except for low blood sugars or really unexpected highs, just don't even check. It's too confusing.
Yes, and just as a way to look at the trend, stay in the zone, the minutia of the number per se is not what matters. It's the overall pattern. Can you identify a specific pattern that you want to change? That's what matters.
Yes, that's right. Well, today we've talked to Dr. Grazia Aleppo about the use of CGM in clinical practice. I want to thank you for tuning in. Please take a moment to download the Medscape app to listen and subscribe to the podcast series on type 2 diabetes. This is Dr. Carol Wysham for the Medscape In Discussion Type 2 Diabetes podcast.
Thanks for listening to Medscape's In Discussion Type 2 Diabetes podcast series with our host, Dr. Carol Wysham. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on type 2 diabetes.